who might be a good fit for some of the services that you all offer.
We have a senior center, which is very lively. Get out there. There's people out there with all kinds of disabilities. And so many people still wait so long to bring in hospice. They think they're going to die in a week.
It would also be a very poor business model for hospices to, kill their patients.
Hospice is a taboo word, and we need to change that for sure.
Do patients get on services too late? Absolutely.
And what people don't understand is, a hospice is not a place. It's
Right.
a concept. Working on solving all the world's problems, right?
Today, we are joined by Kathy Hinkleman from the Village of Schaumburg Nursing Division. Kathy, for those who aren't familiar with who you are, or maybe more broadly, the Village of Schaumburg Nursing Division, can you share a little bit about yourself?
Sure. So I am fortunate enough to work for a very unique division of the fire department. We are the Nursing and Senior Services Division, actually is our whole name. And we actually offer 3 different service lines in 2 locations. So we have a nursing office that both provides nurses who can do either in-office or in-home consultations and services for people. As well, in that office, we have a very robust loan closet. So durable medical equipment for a cash deposit, you use it for 90 days, you get your money back. So it's all free, and so are the nursing services. And then across town, we have a senior center, which is very lively. Lots of activities going on there, bingo every day. And then in between, we have a hot lunch that we serve every day, which is donation-based. So if you can't pay, you still eat.
And the secondary location that you were talking about, they call it the barn, right?
They call it the barn.
Okay.
They do, yeah.
For a very good reason, right?
It is a big white barn.
Okay, perfect.
Yes.
So in terms of the village of Schaumburg, I know different areas have, maybe some nursing services available, but I feel like the village of Schaumburg specifically, there's just a lot of different services that are available to your community members.
Yes.
Maybe we can talk for a moment about, who might be a good fit for some of the services that you all offer.
Yeah, so one of the groups of people that benefit from us are people who are homebound. So that's always important to bring services in. And those folks don't always know that there are in-home doctors that are available, services like palliative and hospice that come into the home. So we help provide like a bridge for that gap of knowledge that people have. But we also do provide services for those folks on our own, like, maybe they take 30 medications or something crazy like that, and they're not always taking them the right way or at the right time, or they don't have refills. So we do a lot of that. We also help people navigate the healthcare system. It's really complex. It's only getting more complex. So folks who may not be able to navigate a portal on their own, we can help bridge that gap as well. We talk to physicians. We talk to home health care companies and help people just get in the know. They'll come home from an ER visit and they'll have absolutely no idea what they're supposed to do for follow-up. So,
I think for homebound patients, it's a very vulnerable population, right? They might not get out to the doctor that often. It's a real, by definition of homebound, it's a taxing effort for them to get out of the house. It doesn't mean that they can't ever leave the house, but it's a taxing effort for them to leave. And to speak to, when they do go to the ER, let's say, the medical system is very good at adding on medications, very good at that.
Yes.
You see patients with like 30 different medications. Can you speak to maybe some of the, from your experience, maybe a specific case or, patients that the issues that they're running into with so many medications, right? Or taking the wrong dosage of a medication that might have been changed.
Yeah. So polypharmacy is a huge issue. Obviously, I look at their medication lists. I'll often share those with a pharmacist to make sure that everything's good. There are medications that have to be taken. I have a specific client that I think of. He takes magnesium 3 times a day, but he also takes a plethora of other medications. And you really have to keep some of those medications at least 2 to 4 hours away from the magnesium. So then it becomes this, sort of puzzle, if you will, where we're putting all the medications in the right spot so that none of them interact with each other. He's probably a prime example of someone needing to manage his medications because he's not capable of doing it on his own. And when you talk about adding on medications, oftentimes when people go to rehab settings after a hospitalization, they'll add medications. And so then they come home with this new list of medications. And it's slightly different, typically relatively the same, but then there's some add-ons. And so then I work with the primary care physician to say, do you want them to continue on this? They were put on it in rehab. And oftentimes the answer is no, I don't want them to stay on it, so that's definitely an issue with sort of that lack of communication within the provider realm. And then we sort of function as the interpreter, if you will.
I'm even thinking of a case we had caring for a gentleman, and while his wife wasn't our patient, the daughter was involved, and she's like, Mom, something just seems off. You're a little more confused lately. Obviously, she's under a lot of stress. So could this be stress related? Sure. But she'd been taking different medication in and out of the hospital herself. And it wasn't until her daughter is looking at the pill bottle and she's like, Mom, are you supposed to be taking this dosage? I thought the doctor's office called you last week and said, you should be taking half of this dosage. And she's like, maybe, but she couldn't remember. And so those almost like verbal, orders, those changes, who's writing them down? Who's making sure the most accurate list
a lot of that stuff gets lost in translation. And, that's kind of where we come in. Like I said, we're kind of like the translator or interpreter for a lot of the medical pieces. So the people of Schaumburg are really lucky, because in addition to our services, there's also the township has a nurse. So we're the village. And there's the township has a nurse as well. And they also provide transportation. Very nice. And so does the village. There's 2 different transportation options. And like you were talking about earlier, when you're homebound, it's taxing to get out of the house. Right. What if you don't have a car? What if you don't drive? So those services, we can link them up with as well.
Perfect. In terms of the people who you see, right, in the home setting, issues or maybe barriers to them seeking out services like palliative care or home health or hospice. Can we talk a little about that?
Sure. They don't even know what it is as far as palliative goes. A lot of people need education about what palliative is. And if they've heard of it, they always immediately link it to hospice. And they're like, well, I'm not, there yet, And I actually have a younger person on my caseload that is in her early 40s, and she is bedbound, not just homebound. Wow. But bedbound. She has, a very debilitating chronic disease that she's had for quite some time. She lives with her parents, and I just got to the point where I felt like I'm not enough, for you. And so I did talk to her about palliative, and initially it was, no, I'm not ready. And I said, no, this is a good thing for you. And for her, not just, the sort of looping in all the providers, that coordination of care would definitely be helpful for her because she does have multiple providers. And her primary care comes into the home. Okay. She has a dentist that comes into the home, so she's got a lot of home services, but then she sees neurology via telehealth. because she can't get to the office. But somebody needs to coordinate all these folks, right? And so I recommended it to her primary care physician. I said, this might be a really good option for her. They came out, they said yes. And she's already had the visit. The primary care chose the palliative company. They came out and she was so happy, so it's someone introducing that to them, someone with the knowledge about it, which is the big key piece. I've actually told people, it might be time to bring on hospice at a certain point. And again, there's that scary thoughts because so many people still wait so long to bring in hospice. They think they're going to die in a week if they bring in hospice, and I said, no, those people waited too long. You can have hospice for quite a long time and be comfortable, much more comfortable for that length of time if you bring them on earlier, when it's appropriate. But there's a knowledge deficit on the physician point too. I think oncologists are great about it, but primary care physicians, I think, hesitate to bring it up. I don't know if it's a lack of knowledge, probably not. It's more of a discomfort in the conversation with the patient. I think that's where it comes from. That would be my opinion.
I think that, people they think that signing on to, speaking specifically about hospice, people think that when they start services, oh my gosh, I'm going to die right away. And I don't have a crystal ball.
Right.
It would also be a very poor business model for hospices to, kill their patients. That would be a very poor business model.
Yes, it would.
Do patients get on services too late? Absolutely. Right. They don't start
for the most part. Yeah.
They don't start services soon enough. I've had patients on service for 3 hours.
Yeah.
I've had patients on service for 4 years.
Sure.
And everything in between. I find that when people, maybe are open to that discussion or they're curious, right? They're like, hey, something's not working for me. I usually start by, what's been going on, right? Can I give them like a bullet point list of, oh, we're going to do this, 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 and this. Okay, we can do that, but I need to know, you probably want to know as well with your patients that you're seeing, what's been happening, right? Because unless we have that information, we can't know how to help them.
Right. Without a full assessment, you can't customize the care, right?
Yes.
They need to tell you what their wants and needs are, and especially at end of life, I think it becomes so important for people to voice what they want, because a lot of us in our day-to-day lives, we do what we're supposed to do, what we have to do, not necessarily what we want to do. So at the end of life, that's the perfect time to tell people what they want, what they need.
And this is this is a goals of care conversation, right? And this, I believe, it should be discussed over and over and over and over throughout the course of care.
For sure.
What I put in advanced directives today is probably going to be very different from what my advanced directive will look like in, 50 years, 40 years,
Absolutely.
Depending on medically where I'm at. I've had patients sign on to service and they haven't revisited these advanced directives since they signed it when they were, 45 years old.
Yep.
Okay, well, I want everything done. I'm going to put my initials right here. Then, the family's pulling this document out from God knows where, and looking at it and saying, well, now my mom can't speak for herself. I have the document, great, but she said she wants everything done. Now, what are they supposed to do with that? That is a lot of pressure.
It is a lot of pressure. Being the POA for anybody in, the medical realm is It's a lot of pressure, especially if there isn't something specific written down. Or like you said, it's
Yes.
so old that is it really still valid, you know? And then, you know, they are left with making that decision. And people don't want to go against what they see in writing. But the reality is, if it was made 10 years ago, 15 years ago, and things have changed in that time frame,
Right.
it's probably not still valid.
Right.
But it is a lot of pressure. I think it's also interesting when you see that an elder person has put that they don't want things to happen, and then you have family that steps in and they want to change that.
Yes.
And I think we see that more often because they get scared to lose that person, and they kind of forget, you know, that this person, this is what they wanted, you know. So
we see that a lot in hospice with, you know, family members who may be very well intentioned, but in many cases have not been part of that day-to-day care, seen the decline in the person. They come in from out of town. They're like, oh my goodness, why isn't anyone doing anything?
yes,
How can you possibly, you know, leave her in this condition or leave him in this condition? Let's get him off to the hospital, right?
Oh,
and,
definitely.
And it's, you know, we've been there, we've done that, we've done this,
Sure.
and we see that a lot. And so it's, you know, trying to get everyone on the same page, which can take time. And I don't know. Unfortunately, sometimes it doesn't happen. Right?
Yeah, I think that's why when you do the goals of care conversation, including family in that conversation is important. It's not always possible.
Yes.
But, you know, you bring up why is this happening? And like they live out of town. You know, we would see that when I worked in the ER, we would see that a lot on holidays or Mother's Day.
Yes.
Nobody had been to visit this person in, you know, a great length of time. And then they go for the holiday and they're shocked to see what they find. And you bet they're off to the hospital because something's got to be done. But, and that's, I think, sometimes the disconnect with the patient and then their family members.
Yes. I can think of a case we had, a woman, her son would call like every day, right? Mom, how are you? And she was starting to become more confused. She was very good at hiding it. And so before she knew that phone call was going to come in, and she would watch the news. She would look at the weather and she would say, oh my goodness, today is a Monday and it looks like it's, you know, it's going to be sunny all week. And her son's thinking, oh, she is sharp. Yeah. She knows everything that's going on. So when that person comes into town and sees a completely different picture, it's, you know, that exact family member. Yeah. What has everyone been doing? When the panic ensues, and then usually the ER visit follows.
Absolutely.
And I think, you know, speaking of goals of care conversations, when people are choosing a healthcare power of attorney or a financial power of attorney, it's very important to, you know, be selective in who you're choosing to do that for you.
Yeah. And
making sure that that person supports your wishes, because you can tell them anything you want. At the end of the day, you know, what's someone going to do once that document is completed? Yeah. It can get very messy.
Yeah. And there's a capability component to that too. You know, just because you trust someone doesn't mean that they're going to be able to function under the pressure that we talked about earlier, because it is a lot of pressure. Yeah. Somebody's really got to have, you know, that capability to make the decisions that are hard.
Generally speaking, you know, patients who are homebound, right, whether it's hospice or home health or any sort of support that they need, what do you feel like, you know, aside from education, what you're hearing from people in the home setting, do you feel like there's a fear to seeking out information, or just truly they just don't know what's out there? What do you see?
Yeah, I mean, I think fear is definitely part of it. That might be one of the reasons that they became homebound is they got scared to go out and they got scared to see what's wrong with me. Why do I have these symptoms? So they might shut themselves in from fear. Certainly there's a knowledge thing. And then just, I think a lot of people just isolate themselves to a point because maybe they've become a little bit mobility challenged, right? And so they don't want to go out because they have to use a walker and they don't want anyone to see them using a walker. So there's an embarrassment to it. I always tell people, I'm like, hey, whatever works,
Right.
get out there. There's people out there with all kinds of disabilities and
Yes.
they're out there,
Yes.
So I do encourage people, if they're capable, obviously, of getting out there and staying out there for as long as you can. And I see that a lot at the barn at our senior center. There's people with walkers and canes and rollators, and there's even people who are in wheelchairs, that come out. Staying social, staying, in the game, if you will help someone, I think, remain not housebound for as long as possible. Yeah.
Isolation itself is such a big issue with seniors.
Oh, huge.
Someone loses start. You don't go out. You're not exposed to what's happening around you. You will decline.
You will. Yeah, absolutely. And cognitively, I mean, the research is clear that isolation will, accelerate your cognitive decline because you're not actively engaged.
Right.
So it's like you don't use it, you lose it. If you don't use your brain, and, we use our brains a lot when we engage with people or go somewhere and go shopping or go to the barn and have lunch or play bingo. You're really using a lot of your brain that you don't when you're sitting in front of the TV by yourself.
Right. Right. For someone who was homebound, who may be, receiving services through the village, what advice would you give to those people or their families? How can they seek out, to initiate services through you?
Oh, through me? Oh, our consults come in through a lot of different ways. We get a lot of referrals through EMS, which is why it's so great that the village decided to pair us with the fire department, because there's people that call 911 frequently, and they need more than episodic care, so we get looped in through that. We have a great consultation system, if you will, and we get referrals from EMS at all hours of the day. And we respond to those as able and pretty quickly most of the time, because there's 3 nurses for the village right now. And we get referrals from the police department. So the police department has social workers. We get a lot of referrals through them, neighbors, family. I mean, those are all the ways they come in. They come in by phone. They come in by our electronic consultation system. We get consults from providers of services. So caregiving services. Some companies that provide caregiving services in our area, I have good relationships with. Well, they might get called in for, my mom needs a caregiver now. And when they go out, they think, well, you live in Schaumburg. You could benefit from one of the nurses. And so we'll get consults that way too. We get it from all angles.
That's such and I'm not sure if it's unique to the village, but what a fantastic idea, right? Before someone has maybe directly called you, someone else has identified that there's an issue, right? So they see that this is happening and they're really trying to link those two things together, right? We have this service that's available. In order for someone to receive those services, is there any criteria that they need to meet or not necessarily?
So criteria is pretty simple. You need to be a resident of the village of Schaumburg and you need to be willing for us to come out.
Sure.
So
that's reasonable.
Yeah, because we will get consults from neighbors or family members, and when we make the phone call, and we try to make a phone call before approaching the residence.
Sure.
It's not, we don't always get a hold of people on the phone, and we give it quite a while before we actually make a home visit kind of a surprise. Because I don't know about you, but I don't want somebody showing up on my doorstep.
Right.
So we try to do that. For the most part, we're successful with getting somebody on the phone and talking to them, letting them know what we can help them with. And oftentimes there's an initial declination of services, but we'll, sometimes we'll push it depending on the situation. Well, how about if I just come out and see you and check your blood pressure and that kind of thing, and we can go from there. And so that sometimes gets us in the door,
That makes sense.
But really, it's simple. No financial component to it at all.
I think we see the same thing with hospice. Someone may have initially been referred by the oncologist or some doctor or a family member. Someone sees that a change is happening, and we might reach out to the patient or their family and explain what services might be like. And some people are accepting of that initial visit, and some people say we're not quite ready yet, and that's okay.
Sure.
And sometimes we end up following these people for weeks or months, sometimes, until they've accepted that maybe this care is needed. And I think that it's different for everyone. For hospice patients, I would say, I wish so badly that we could change the word hospice, but then I feel like whatever we change the word to, people would start thinking about that word. Yes. I've heard it called everything from, I don't know, it's palliative, but it's not palliative, but those are two very different things. Some people call it comfort care. The reality is, for these people, we are talking about honoring their wishes, whatever that is. If they don't want to go back to the hospital, and maybe we can talk more about this, what is the person's plan? I don't want to go back to the hospital. Okay, great. I'm glad we have acknowledged that, we have, said that, but what is your plan? Is there a plan to make this a reality? Because I can say anything that I want if I don't have caregiving, if I don't have the proper supports in place, if I don't have the proper service in place. Okay, what's going to happen? It is a matter of time before they're back in the hospital. I didn't want to go here. Okay, I hear you.
But you also didn't want to bring in care.
Yes.
So it becomes that like catch-22, right? Yes. I don't want to go back to the hospital, but I don't want services in the home. Well, which one do you not want more?
Right.
I have a guy, I actually had a guy because he actually passed away. He did not want to go back to the hospital. He was adamant about it. And I understood that, and I was all about it. And he was on hospice for a short time. And then he actually came off of hospice. So we were working on his congestive heart failure and some other issues. He came off of hospice and he was doing fine, and I was seeing him on a regular basis. And then he started to have a new problem, and it was, getting worse. And I kept telling him, like, we need to bring them back in,
right,
or I don't want to go to the hospital. I'm like, exactly. But in the end, he hesitated too long, and he ended up dying in the hospital, which was not what he wanted, but that's what happened.
Right.
One night in. So
we have patients that I shouldn't call them patients. We have people that we speak with who may be contemplating services. And it's like every time I talk to them, I just got back from the hospital. Okay. And I just spoke to you 2 weeks ago. Oh, I've been in the hospital twice. Okay, so what happened? Can we send a nurse out to see you? I don't think I'm quite ready. Okay, I'll follow up with you in 2 weeks.
And going in and out of the hospital like that, it's exhausting.
Yes. Yes.
And it's expensive,
right,
for even if the patient isn't bearing that cost, if they have excellent insurance or what have you, the system is bearing that, right?
Right.
The system's bearing that cost.
And what we see is patients who have these frequent hospitalizations. Not only is that a flag, right, for considering a goals of care conversation and getting those things done. But the patient overall, what we see is decline. Mm-hmm. Every single hospitalization, you might see a little bit of an improvement. They had a UTI, started antibiotics, whatever the case is. But over time, they're never, I shouldn't say never, but rarely are they getting back to that baseline that they were at before the hospitalization.
Oh, yeah, because you think about, where do you spend most of your time when you're in the hospital? In the bed.
Yes.
Okay, so that deconditioning starts right away. Yeah. And it's, it happens so fast and it elevates so much that it's so hard to get back to baseline, because it's so much harder to recondition than it is to decondition. Yep. And you'll see it happens so fast. Yep. And then they can't walk when they get out of the hospital, and home PT, it's great, but like, how much is it really going to bring you back up? Yeah. Especially if you weren't in great shape to begin with. Yeah. So that's really rough.
And I think those patients who have had frequent hospitalizations, that's a perfect opportunity for the hospital to get in a palliative care consult.
I agree.
It is the perfect time. I've really seen some fantastic palliative care consults from the palliative care teams at the hospital too, explaining in very clear terms, this is what's happening right now, and this is probably what's going to happen in the future. That can be a difficult conversation for families to hear, but by having those conversations, okay, we've got to do something, right? I wish that those conversations happened more often.
Agreed.
If, and maybe if palliative care teams aren't supported enough in having those conversations, or there's not a robust program, whatever the case may be, hospitals can pull in, a hospice and palliative care agency would be more than happy to come in and have those conversations with patients and families too. But the more that we have these conversations, I would hope, that's one of my hopes, is that these conversations will become more normalized.
Oh, that would be
It's
amazing.
not a matter of if people will have to have them, but when. And the more that we can talk about them openly, it would feel like less of a taboo subject.
Yes.
I don't know.
Less of a taboo is right. You hit that right on the head. That was the word I was thinking of.
Yes.
Hospice is a taboo word, and we need to change that for sure. Because there's so much that can be done. Yes. And they can have such a better quality of life if they just bring in the help. And I mean, hospice is they're the last 100% covered by Medicare still, right? So, I mean, hey, what's the downside?
Yes. I hear things from families, I'm not ready because I'm not ready to stop taking all of my medications. Yeah. I still want to go out of my house. What if I get an infection? Okay. We're not going to stop you from taking all of your medications, but if you can't swallow, I don't want you taking a bunch of pills either, unless you want to choke. I mean, we don't want you to do that either. Yeah. We can talk with you about maybe alternative forms of that medication, right? If those are for your comfort, let's talk about that. Yeah. Oral antibiotics, you can do that too. There are still many, many, many interventions that we can do in hospice. It's going to be a long.
It's road. Surprising to me that it is still that we're still having this conversation, because 20 years ago I was thinking, why are people so against hospice? But it's still that way. I think we've made some headway for sure, but we have a long way to go. You're right.
I was just at a birthday party over the weekend, and someone was talking to me there about a family member, right? And I had seen this family member at the previous birthday party, like a couple months prior, and I'm, doing this for like 10 years now. I'm looking at this person and I'm thinking, I think they need services. Of course, I didn't say anything.
Of course.
But, I came to find out that the person then went to the hospital and it was like aspiration pneumonia. And, they're very upset, talking about how now the person's going to have to be on a vent. And it's, you just hear these stories that are really, really heartbreaking. And you see the effect that this has on the family. Everyone's stressed. Everyone's sad. No one knows what to do. I just wish that there was more conversation around this before we get to that point.
Oh, absolutely. And what people don't understand is, hospice is not a place, it's a concept.
Right.
It can be done anywhere,
Right.
wherever the person is. And that whole team is now working for you.
Right.
It's not just a nurse.
Right.
It's not just a doctor. It's a whole team of people. You're a social worker, and I always tell the families, like, you could benefit from this. You could have the services of a social worker come in and help you get through this, because this is hard stuff.
Right.
I don't know what we do.
I guess we'll keep working on it, right?
Keep working on solving all the world's problems, right?
I don't know if there was anything that we didn't touch on. I think we hit like most of everything. Was there any words of wisdom or things that you would like to pass on to the people in your community, or people in general, that, about receiving services at home through your local village, or, getting information on services?
Yeah, I mean, I think the biggest thing we hear, and oftentimes people, their first exposure to us is the loan closet, because they need a walker or they need something. Their doctor or whomever in the office told them about our services. You can go over there and you can get a wheelchair, you can get a walker. And then they find out, oh, you have nurses here? Oh, I've lived in Schaumburg for 25 years and I never knew you were here. You never know what you never know what exists until you need it.
Yeah.
Right. So, that's why we try to do a lot of outreach and let people know that we do exist and that our services are here, our equipment is here, the barn is there, because I still hear it from people. No matter how much outreach we do, they didn't even know that we existed. And I'm like, well, that's because you didn't need us.
Right.
So I guess the same thing goes for palliative and hospice. People don't understand what it is until they need it, and someone explains it to them, and they explain it to them in a way that makes sense for their needs, because a lot of people have a misconception, like we've talked about. Hospice is, I'm in a bed, someone's putting me on a morphine drip, and I'm going to die in 2 days. No, that's not what it is.
Right.
A lot more to it.
And I think probably part of the job will be having these conversations over and over and over and over, because we may have said this 25,000 times before, but maybe it's the next time that someone will actually hear it, right? Maybe they're in the right headspace, or someone else said it to them because they heard it. You never know how the information will get
I think
out
you're
there.
right about the headspace, and that goes back to when you need it, or when you're capable of receiving that message.
Yeah.
So,
Yeah. Well, thank you for joining us.
well, thanks for having me. I thought this is great, get the word out in all different ways. And this is just the latest and the greatest, right?
Thank you.
Yeah, you're welcome.